Our next speaker is Professor Rodney Sinclair from Melbourne, Australia. He's a professor at the University of Melbourne, and his talk will be on female pattern hair loss, combination therapy with low-dose oral minoxidil and spromola.
Thank you, and thank you to the organisers for allowing me to give the presentation. By way of background, minoxidil is an FDA-approved oral antihypertensive medication. It's licensed for use in doses up to 100 milligrams daily. It's been known for a long time that it stimulates hair growth, but its use in female pattern hair loss has largely been limited by concern about potential adverse effects, including postural hypertension, fluid retention, and also hypertrichosis. Spironolactone is another FDA-approved oral antihypertensive. It's got known anti-androgen activity. It's used off-label to arrest the progression of female pattern hair loss, and it's also been shown to be able to produce hair regrowth in some women with female pattern hair loss. And we know that the combination of spironolactone and topical minoxidil seems to have an additive effect in hair regrowth. What we were interested in doing is looking at the use of oral minoxidil together with spironolactone. And we did a case series of 100 women with stages 2 to 5 female pattern hair loss scored using this visual analogue scale below. So it was women between stages 2 and 5, and they were enrolled in a pilot study, and we followed them for 12 months. And in addition to scoring their hair density, we were also interested in looking at their hair shedding, and we had also developed a hair shedding scale, which was presented as a poster here at the conference and also published in the British Journal of Dermatology. And that's a 6-point visual analogue scale, and we score the hair density using the 5-point scale on the last slide and the hair shedding scale using the 6-point scale. And the way we use that the shedding scale is we ask women on an average day, how much hair would you shed? And so for the women enrolled in this study, the mean age was about 48 years, range 18 to 80. The mean hair loss severity was 2.79. The mean shedding score was 4.82, and the mean duration of diagnosis was about 6.5 years. We didn't notice any change in blood pressure in our patients, or the mean change was about 4 points on the systolic and 6 points on the diastolic, and side effects were relatively infrequent in the doses that we were using. We saw side effects in 8 women, 6 managed to continue the treatment, and 2 discontinued due to urticaria, which we think was related to the spironolactone rather than the minoxidil. So with regards to the hair density, so the baseline score, the mean was 2.79, so it was about just below a stage 3 on this scale, and the mean reduction in severity score was about 0.85 at 6 months and 1.3 at 12 months. So the average woman moved one stage on this scale, or 1.3 stages on this scale. With regards to the hair shedding score baseline was 4.82, so they were sort of in between, just very close to a 5. So most of them were shedding that amount of hair on a daily basis. And the mean reduction in hair shedding was 2.3 at 6 months and 2.6 at 12 months. So we managed to get most of the women down to that sort of level of shedding from that level of shedding. And so what we're presenting is a prospective, uncontrolled, open-label observation pilot study comparing looking at once daily minoxidil 0.25 milligrams together with spironolactone 25 milligrams daily, and we found it was safe and in our cohort of patients largely effective in treating female pattern hair loss. We're now progressing this, and so we're at the stage of having received ethics approval to initiate a phase 2B multi-centre placebo-controlled dose-ranging study with an active comparator to investigate this further in women. And we've also got ethics approval to initiate a phase 2B multi-centre placebo-controlled study in men, because we've also got significant evidence of response in men treated with oral minoxidil as well. We have also looked at chronic telogen effluvium and trichodynia, and in a separate study we looked at 36 women who had greater than 6 months of chronic hair shedding without visible reduction in hair density over the midline part, no follicular miniaturization on scalp biopsy, and we looked at 6 months treatment with minoxidil monotherapy, so no spironolactone in these women, looking at doses between 0.25 and up to 2.5 milligrams daily. And what we found was that the hair shedding scores at baseline, 6 months and 12 months, were analysed and compared. We found that the mean shedding score baseline was 5.64, so they were closest to the maximum on that hair shedding scale. The mean duration of diagnosis was about 6.5 years, so they'd had it for a long time. And we found that the reduction in hair shedding score was 1.7 at 6 months and 2.58. So we didn't achieve the very low levels of shedding that we saw in female pattern hair loss, but we could significantly improve the shedding in chronic telogen effluvium. Obviously, we're using higher doses of minoxidil in this study in many of the women. So there were some patients who developed postural dizziness, but it was usually transient and it resolved with continued treatment. One patient had ankle edema, probably because we weren't using spironolactone in this study. It was probably masking us to a degree in the female pattern study. And we had a number of women who developed hypertrichosis. Generally, this was mild and most often didn't require treatment. We've also noticed some changes in improvement in hair density over the parietal scalp. We've also seen some changes or improvement in hair density bitemporally. And many of you who've used topical minoxidil will notice that the women with topical minoxidil often get that temporal hair growth, and we see that perhaps in an exaggerated form when we use oral minoxidil. We've also used it in a range of other conditions. So this is actually a case of manilothrix. So this is a woman with manilothrix. You may be able to make out some of the beaded hairs on the microscopy. These are baseline photographs, and that's at 6 months. And so we've managed to achieve cosmetically significant improvement in their hair density. We've also used it in chemotherapy-induced hair loss, alopecia areata, and a range of other conditions, but I won't present on that. But we have had 10 years experience now of using oral minoxidil. We've treated almost 4,000 separate patients. We've used doses ranging up to 20 milligrams daily, predominantly women but also men. We generally commence patients at low dose, review them at 3 monthly intervals. We'll sometimes escalate the dose. In men, we use it in combination with finasteride or dutasteride in the majority of patients, but occasionally we use it as monotherapy. In women, we often combine it with spironolactone, but we've also combined it with cyproterone acetate, flutamide, bicalutamide, alternate antiandrogens, and occasionally we use it together with a combination of spironolactone and flutamide. And in our experience over these last 10 years, we haven't had cases of syncope, tachycardia, pericardial effusion. We haven't seen any ECG abnormalities. So I think we're now at the stage where we filed a provisional patent 12 months ago and are now taking out an international PCT on this and starting to present the data. We're now progressing to the next stage of actually doing formal placebo-controlled studies with hair counts and hoping to start the phase 2B studies in March next year to do some dose ranging studies and work out what the lowest dose of oral minoxidil is that we can actually get away with and still stimulate some hair growth. And that study is also going to include some pharmacokinetic sub-studies. And then, if all goes well, we'll be looking at starting phase 3 studies in 2017. So, thank you very much.
Okay, we have a few minutes for questions, 3 minutes. Does anybody have any questions? I think there's questions there. Please ask.
Yes. Given your experience, Rod, could you tell us which is your first therapy for women? This combination therapy, or you prefer to put them first on finasteride or topical minoxidil?
Spironolactone has been my first-line therapy for women for many years, and we've used it. We used to use spironolactone together with topical minoxidil. One of the things that we found with topical minoxidil is achieving long-term compliance. We've often found that women are good with it for 3 months, 6 months, but by the time we get to 3 or 4 years, not many women are still compliant with the topical minoxidil. So we're now moving probably to a first-line strategy of using the combination of spironolactone and minoxidil together as our first-line treatment. And we find that it's got very good adherence, and we've now got patients who've been going 10 years with it, and we find that they have very little difficulty continuing with the treatment.
Please.
So usually we think about female pattern hair loss as not having a lot of shedding associated with it necessarily. And it looked like your scale was 4 point something for shedding with the female pattern hair loss. What were the number of hairs that were actually in that little group? And do you think that those women actually had a combination of female pattern hair loss and follicular fluid?
In the hair shedding paper that we published in the BJD, we actually looked at that. And one of the things that was interesting is before we showed people the visual analog scale, we'd ask them, do they shed a lot of hair? And sometimes women would say, no, I don't shed much hair, and they'll point to stage 5 on the scale. And other times women would say, I shed lots and lots of hair, and they'll point to stage 3. So women's assessment of how much hair they shed is often based on what they perceive to be their norm. And they don't actually have anything to compare it to. Now, when we did those scales, we did actually count out the number of hairs in the bundles. But when we've actually had women point to the scale and use the scale and then bring in bundles of hair and show it, we find that it doesn't correlate that well to the actual numbers of hair shed. Because of the size of the images and how they're reproduced. If we actually showed women the bundles of hair, rather than the visual analog scale, would probably get a better, more accurate representation. But we did validate this scale in terms of test reliability and accessing. But we did find that women with female pattern hair loss do actually shed more than normal. And we looked at the comparator group we used was 13-year-old schoolgirls, and we looked at shedding rates in those. And that I haven't presented all that data here, but that's all published in the BJD.
Any other questions? I think then we'll call it quits. I want to thank everybody. I want to thank my co-chair, Valerie Callender. I want to thank all the speakers. They were all wonderful. And now we're all going to have lunch, and bring your lunch toward the table. Snacks, sorry, not lunch, snacks. Okay. Snacks.